I'm going to pass off for session 3, special extraction scenarios, to Dr. Blandine Mondesser, who's going to introduce the upcoming speakers.
So it will be on special scenarios with Dr. Moussa Saleh, Dr. Sunil Kapoor, and Dr. Rob Schaller. And see you after for a great discussion.
Good morning, everyone. It's my pleasure to speak with you about lead extraction via femoral approach. My name is Moussa Saleh. I'm one of the electrophysiologists at Northwell Health. I have no disclosures related to this presentation. Femoral lead extraction historically has always been done via the superior approach. The decision to extract is always individualized, comes based on the indications, existing hardware, patient condition, and the extractor's experience. And the use of femoral approach historically has always been looked at as a bailout approach, though there are centers that advocate for it to be primarily as the primary approach. There tends to be high success rate and low complication rate when approaching lead extraction via the femoral vein. The need for this approach tends to be unpredictable, so it's very important to have a firm understanding of the tools and the techniques that are needed and know when really to send to a more experienced operator. And overall, experience using the femoral approach may be limited, and so most centers do consider it as a bailout method. It is important, however, to understand why we should be able to use femoral lead extraction as an approach, and that's because it really significantly increases our success for both clinical success and complete procedural success during an extraction. It takes us from the mid-80s or low 80s up to the mid-90s, so it's important to remember that. When do we really approach from below? There are centers that look at it as a primary approach. It's important to do it in places in times when you can't do a superior approach. So either the previous leads were cut or they were abandoned or the lead spontaneously severs at some point during the patient's life and you have to take it out from below. You try to take it from up top and you break the lead, and so you really have to go from below. This tends to happen because of the tensile properties of the degree of the lead, and it depends on the degree of lead scarring. Older leads like Inditech and Reatas tend to be more likely to have this happen to them. Leads with full tensile strength, things like fine lines and longevities also tend to have that as an issue. The need to maintain vascular access for reimplantation, especially when the veins are occluded, may require you to go from below. I'll show you some cases about that. The lack of progress from the superior approach. You have lead remnants from cardiac surgery. So someone gets some CT surgery done somewhere and the surgeon just cuts the leads and does not remove the lead fully, and you don't really have access to remove it from up top. And of course, extraction of leadless pacemakers. Some centers do consider femoral approach as their primary approach. You may have to go femoral because you plan to reimplant via the femoral route, and so it just makes it easier. You're at a center where you don't have availability of powered superior tools, so you really don't have a lot of options. If you can't get the lead from up top, you have to go from the vein below. Others really have suggested that this is much safer, especially for pacing leads. And so when it was looked at in this study from 2013, really they demonstrated that pacing leads, particularly atrial and coronary sinus leads, had better safety outcomes when removed via the femoral approach. They attributed this truly to the fact that they probably were more aligned when they came from the femoral vein and being able to pull down. The biggest disadvantage for this is that if you need to reimplant and you don't have vascular access from up top, you're unable to maintain vascular access. This really does, however, negate the use of power tools, which were not used in the study because they just compared traction from up top to traction from below with a needle eye snare. So it's important to remember that. This is an example of a case that I did at a center where I did not actually have access to power tools from up top. The ICD was only a year old. The patient was infected. The leads needed to come out. The patient, unfortunately, was very heavily calcified right here, and I was unable to pull the lead through. I was worried that if I continued to pull, I would just unwind the rest of the coil, but I wouldn't get the lead tip out. It would just get stuck here. So then what I did is I put a microsheath in, and as you'll see, I really love the microsheath. It's my workhorse for a lot of these extractions. It provides you a very big diameter to be able to put your tools through. I put an angilis, I put a snare, I grabbed the tip of the lead, I cut on the outside from here, and then I just pulled the lead back in and pulled it out through the microsheath. Sometimes you have to be able to maintain vascular access to be able to reimplant, and so that requires that the lead continue to be connected to the myocardium, right? If it's not attached, you're unable to maintain a rail. And so when that happens, you have to maintain a rail somehow. So if you grab onto the tip of your lead from below and provide counter traction, you're able then to move and advance your power tools over. And by doing that, you then are able to maintain access, and you're able to pass your wires through. You get your wires down, and then you have access. So you can see once you get here past the occlusion, you can let go of your lead from below, and then you're able to pass your wires, and voila, you maintain access from up top. There are some centers that do use the tandem approach. So what they do is while they're removing the lead from up top, they have access from below. You snare the lead and provide counter traction. This allows you to safely provide a rail with decreasing the risk of you, one, snapping your lead from up top, two, decreasing your risk of SVC perforation or tear. There's high success rate with doing this. This was looked at in 131 patients in this study. What this, however, it showed is that it doesn't necessarily decrease the risk of cardiac perforation, which we have less control over no matter which approach you do. It's important to have a solid understanding of the tools that you may use. Your femoral workstation, I really prefer to use a microsheath for most of my cases. The different steerable sheaths that can get you in the heart, the different snares, whether a needle eye or a gooseneck or EN snare, the use of a biotome, and the use of ablation catheters. My preference tends to be a blazer because of the flexion hook that you're able to get on it. And of course, there's the AVEIR retrieval system for leadless pacemakers. This is an example of a case where the lead broke from up top and we had to get it via the femoral approach. So an ablation catheter was used. You can see you can wind the ablation catheter around the lead, and as you wind, you're able to pull down. You'll see that as the superior portion is going to come down, so we're able to get this out, and then as you continue to provide traction and counter traction with a microsheath, you will pull this whole Goomba into the microsheath. This is why it's so important to use a microsheath, in my opinion, because you can see this is pretty big. So once I get this in the microsheath, I feel pretty safe I can get this out. Sometimes if you're unable to do that and you don't have a sheath big enough, you end up having to do a cut down in the groin with a vascular surgeon to be able to get the rest of the lead remnants out. So this just saves you that in a lot of the cases. This is another example of a case where multiple leads were abandoned, and so really we just decided to get all of them together. So same thing, took the ablation catheter and wind all the leads together around the ablation catheter, and again with traction and counter traction, able to pull the superior portions of the leads down into the microsheath and able to get the leads out, get them into the microsheath, and you get your leads out and patients extracted. This is a case of a young patient who had a dual coil ICD system placed when he was 7 or 8 years old. He's in his 30s now. He had recurrent VF as a kid, which was later found out to be due to recurrent AVRT that degenerated to VF. He had ablation of his pathway and then had no further VF episodes 15 years after his ablation. His device was at ERI, and he said, listen, I really want the whole thing out. So he was very heavily calcified up here. The lead broke. The only way to get everything out was using a needle eye snare that was advanced up, wound around the lead, and both coils were pulled down, get them into the tip of the microsheath, and then with traction and counter traction, we're able to get it up. This is what it looked like on the outside. You see this and you freak out. And you're like, oh my God, did I just pull the whole valve out? But we do this with TEE. When we looked through, valve was completely intact. There was trace TR at the beginning, trace TR at the end, and he's doing very well now. Sometimes when you go via the femoral approach and you get the lead out, you're unable to get the rest. You have some remnants left. So this is an example of where the body of the lead was removed, but the tip of the lead remained here. And then the tip of the lead actually flew into the PA. So now we had to take it out. So what we did is we advanced an Agilis and a blazer into the PA, took the blazer out, put a snare in, grabbed onto the tip, and you pull it out. We've had this happen in the lung. We've had this happen in the liver. So it's very important to have this set of tools to be able to retrieve remnants that fly to different places. When using a bioptome, it's very important to put a curvature on the bioptome so that you can actually guide it inside the body. Otherwise, it's just straight and you have a lot of difficulty. So bend it outside of the body, put a gooseneck onto it before it goes in the body, then advance it through your sheath. You can use the bioptome to grab onto the distal portion of the lead and then pass your bioptome over, and you're able to pull your lead down. This is another example of a passive fixation lead that also broke from up top. And so same thing was used here. Bioptome grabs, gooseneck snare grabs, and you pull with both. And as you can see, with traction and counter traction, and unfortunately he was left with this, but this is clinically insignificant, so it was left. The gooseneck over gooseneck is also important as a tool to have. So sometimes you're unable to you need the two goosenecks to pull the lead. So one way to avoid breaking a lead like you just saw is to also have a distal gooseneck and a proximal gooseneck. And so once you have your bioptome and your gooseneck on the lead, you let go of your bioptome, you pull your bioptome out, and then you pass another gooseneck over this gooseneck while maintaining hold onto your lead. You pass the gooseneck up, you pass it through your sheath, you pass it up into the body, you pass it over the gooseneck onto the lead, you pass it more distally, you grab onto that end of the lead, and now you have two areas that you're able to pull down on. This is an example. So there are contraindications to femoral approach, mostly if you're unable to get through because there's an occlusion from below. Some have suggested that the presence of an IVC filter will not allow you to go through. We've demonstrated multiple times that you're able to pass a microsheath safely in most cases through an IVC filter. But this is an example of a case where really this was occluded and there's no way to go through. So we were able to pass a wire, get a balloon, dilate the occlusion, pass the microsheath, and do a gooseneck over the bioptome to grab prox and distal portions of the lead and pull the lead out through the microsheath. So sometimes you're able to get past some of these occlusions to be successful. You can also do the same thing using a deflectable catheter and a gooseneck. So if you don't want to wind around because you're worried that the mass is going to be too large to be able to get it through a sheath, you can hook onto the lead with your ablation catheter, and then take a gooseneck and close it down and pull with both to be able to get the lead out successfully. And finally, we need to talk about removing pacemakers that are leadless. So the Avera system is pretty explanatory. You can use their system, but sometimes with Micras, if you don't have access to the Avera system and you want to just extract it the old-fashioned way, the way that we do this is we put a microsheath up and a gillis, a gooseneck through it. The gillis gets you to guide to the micra, and you're able to pull it. I'm going to show you this one more time just so I can go through the steps here. So what's important and what makes it easy here is once you get it around the body, don't aim for this nub in the back first. Once you get it around the body and you're able to get it a little bit smaller, you're able to slowly pull back and get to the end of the device without forcing yourself too hard to just get that part, and then you pull through. All right, thank you so much.
Hi, everyone. My name is Sunny Kapoor. I am a cardiac electrophysiologist at Brigham and Women's Hospital in Boston, where I help run our cardiac device clinic and our advanced lead management center. And I'm going to be speaking about the specific case of lead extraction in patients with LVADs. So I'll start off by bringing up a case, as many of these presentations will have. This is a 65-year-old gentleman with heart failure with reduced ejection fraction. He had a non-ischemic cardiomyopathy. He also had diabetes and presented late last fall for a destination LVAD. His course was unfortunately quite complicated, as is common for patients who have massive surgical procedures. He had a left MCA stroke, trach and PEG, although subsequently decannulated. He had renal dysfunction and was on hemodialysis with a temporary dialysis line. He had recurrent pneumonias with Pseudomonas and subsequently had persistent high-grade Enterococcus faecalis bacteremia. Given his long-standing heart failure with reduced ejection fraction, he had a pre-existing single-chamber ICD, which was implanted in 2017, so on the order of around 7+ years ago, and no real pacing requirement. Given the nature of his LVAD, he is continuously anticoagulated with Coumadin, and his last INR was 2.6%. And we were called to discuss the role of removing the ICD. This is his chest x-ray, which of course highlights the prior sternotomy, the temporary dialysis line, which we can see from the right side, as well as the permanent ICD on the left, with the single chamber, single coil device. We also see the LVAD pump with the inflow cannula at the LV apex. The question becomes what to do with regard to extraction. Certainly, long-term antibiotics can make sense for these patients, as the LVAD is likely to remain in place. There is no surgical plan to remove the LVAD, which can oftentimes be a massive surgery, and so the standard refrain of removing the ICD to remove all foreign hardware does not become applicable here because, again, the LVAD will remain in place. The other question is whether or not we should remove the ICD given the strategy of quote-unquote debulking, with the idea being that potentially that'll help prevent the persistent bacteremia. So it really is a different scenario than we commonly see where patients are having the goal of removing all endovascular hardware. I think it's important to also think about, as is the case with any of our cases, what the pacing requirement is. This patient had none. And as a related to that, the role of a reimplant, whether or not somebody would ultimately need the ICD reimplanted, as again, that can increase procedural risk as well as some logistical concerns. So over the course of the next 10 minutes or so, what I'll discuss is the role of LVAD patients with ICDs, the role of extraction in ICD patients, and some special considerations for extractions in LVAD patients. So just to review, ICDs in the LVAD population is very common. The population of patients with advanced heart failure continues to rise, as is the need for mechanical circulatory support. Around 3,000 LVAD devices are implanted annually in the United States, And many of these are destination therapy, meaning that these patients will have the LVAD with the idea of taking it forward. Technological advances have allowed for patients to have an increased life expectancy with both bridge to as well as permanent destination LVADs. And therefore, the population of patients who are having LVADs is dramatically increasing. It's no surprise, given the nature of an LVAD, that many of these patients will have a pre-existing implanted device, as they have overlapping indications with heart failure with reduced ejection fraction, receiving ICDs, as well as subsequently LVADs. Now, one question is, do these patients with LVADs still need their ICD? And that's, of course, a very challenging question to answer, but does give us some background in terms of whether or not we want to go ahead and either remove or subsequently reimplant an ICD. This is a retrospective registry from the Intermax registry of around 16,000 patients, where they took around 2,200 patients with an ICD and an equal number of patients with a similar propensity score to look at the role of ICD in survival. And as what you can see here is the presence of an ICD was associated with an actual increased mortality risk and an increased risk of unexpected death during device support. And so what I think this is, as a retrospective data, which of course is a little bit challenging and inherently biased, tells us that the routine use of primary prevention ICDs for an LVAD patient is not necessarily the same as was the case before these patients received their LVAD. Digging into this data a little bit further, patients with an ICD were more likely to undergo transplantation and less likely to have LVAD explant for recovery. Again, maybe a selection bias for a sicker patient population. Patients with an ICD had a higher rate of treated ventricular arrhythmias and rehospitalization, although rates of hemorrhagic stroke were similar, maybe supporting the fact that they were propensity matched. Again, I think this data is a little challenging to interpret, but does give us the idea that monosynaptically thinking that patients with a low ejection fraction need an ICD may be true before they have an LVAD, but afterwards, the benefit may be at least mitigated. If we look at subgroups from this study, there's no clear trend from any major subgroup that would suggest an ICD is more important. Again, throughout all of the subgroups that were shown here, including the destination or bridge to transplant subgroups, as you can see on the second from top, there's no real benefit of an ICD. And so if we think back to our patient, the fact that we might not need to reimplant him after extraction, if we choose to go that way, certainly makes it a little bit more appealing and logistically a little bit more easy to go through with the procedure. This is a meta-analysis and a review of other studies that have looked at the role of ICDs in patients with LVADs. And again, this reiterates the fact that there's no clear benefit that has been demonstrated. Again, understanding that this is not randomized control trial data that we might like to see for this type of situation. As such, a consensus scheme of how to treat patients with ICDs and LVAD is relatively conservative. And by that I mean, for many patients, we do not think that an ICD is inherently as needed as it was before the LVAD. One last thing to think about in patients with ICDs and LVAD comes from this very well done retrospective study that looked at consecutive patients who had extraction and looked at whether or not there was repeat infection or mortality. And one of the things the authors pointed out is for patients who had an LVAD, there was an increased risk of repeat infection, as we can see in the middle panel. And so I do think that taking this all together, this might argue towards being still thoughtful of whether or not an extraction is necessary for the indication of infection, but being maybe a little bit more conservative for patients who have, for example, ICD lead fracture or issues with sensing, as maybe simply turning off the lead might be a very reasonable strategy. So let's talk a little bit about the role of extraction in ICD patients. Again, the role of lead management is a little bit unclear as we don't have the randomized control trial data, but certainly for patients where we're trying to look at lead fracture or whether or not they actually just have an issue with sensing of the ICD, manipulating the ICD is something that we probably need to be a little bit more conservative on, just because they might not need the device going forward. However, for infectious indications, there is a concern. We know that LVAD infections are common and oftentimes associated with an increased mortality. And there is this thought that even though we might be leaving the LVAD in place, the fact that the ICD is in the low pressure venous system, it might be more susceptible to a biofilm as opposed to the high pressure arterial system. And so the idea that maybe we just are not going to completely remove all of the bacteria is maybe a little bit more controversial. Then again, there's no consensus on the best clinical practice. If we took a look at some of the studies that have been published regarding LVAD and lead extraction, we see that most of these are retrospective observational studies with a small number of patients. We do see that overall the common techniques of the laser and mechanical cutting sheath, as well as occasionally femoral axis, have been utilized with a high degree of success for complete ICD removal. Again, we don't completely have a lot to leverage from this data, if only because this is retrospective observational data. One specific study to maybe make note of looked at, and again, in a retrospective single center way, bacteremia in CIED LVAD patients. Now, in this group, 89% were treated with antibiotics alone, which of course give a small number that were treated with lead extraction. In a multivariable logistic regression, it showed that blood culture positivity for greater than 72 hours was associated with inpatient death when controlled for other factors. And I think that does give us some hint that if we do think that lead extraction is appropriate, perhaps pursuing this in an early and a more aggressive way might be appropriate for this population. In patients who survived the initial hospitalization, the use of long-term suppressive antibiotics was not associated with composite outcome of death or infection recurrence within 1 year. Again, maybe speaking to the fact that maybe we can remove the bacterial source by lead extraction. Surgical management was associated with a trend towards decreased mortality. Again, very hard to interpret single center retrospective data, but that does suggest that maybe there is a role for lead extraction in these infection patients. The largest single center experience had a total of 27 patients with LVADs and lead extraction. The median duration was around 6 years and had a very high success rate with very low complications. Again, common techniques including the laser sheets were utilized, as well as mechanical cutting sheets, as well as rarely femoral extraction. The majority of these patients had chronic suppressive antibiotic therapy. It is important to remember that CID complications in LVAD patients are common and often necessitate lead extraction. Despite this, recommendations are limited. And I think the recommendations that have been published give us the kind of guidance of trying to make sure we are cognizant of the pros and cons. So in general, when I think about it, I do think of whether or not it is an infectious indication versus a lead management indication. Because again, I think simply turning off the ICD for lead extractions when requested for lead malfunction is a very reasonable strategy. I also think of whether or not the patient needs a reimplant, again, with regards to the logistics. And many times, removing the ICD and not reimplanting can be a very reasonable strategy in LVAD patients. The question of whether destination or bridge to transplant matters is something that I think remains to be seen. Certainly, we do work very closely with our transplant colleagues for the bridge to transplant, as occasionally ongoing infection limits their transplant candidacy, and so it is an important factor to consider, although I don't know if we necessarily have data to speak to that. So in general, we've talked about how LVAD patients with ICDs are common, and certainly the role of an ICD is maybe just a little bit less important than we would have thought before the patient had an LVAD, and that might influence our decision with regards to lead extraction. While there's a lot of data regarding the role of lead extraction in LVAD patients, the exact nature of how to do it and how to proceed is certainly something that is evolving. I do think that indications for infection, specifically Staph aureus bacteremia, still make a lot of sense, but perhaps maybe we need to be a little bit more conservative with lead failure patients. And there are some special considerations that we need to consider. Just briefly, the common lead extraction techniques that we would always use would be applicable for the LVAD patient. One thing to point out is certainly the fact that not every cardiac surgeon is comfortable with LVAD, so having a surgical backup and a mechanical circulatory support team that might be more familiar with that is important. I think it's also important to remember that many of these patients with LVADs have uninterrupted anticoagulation as a goal or as a desire for their MCS team, and I think it is safe to do this for many of our patients with lead extraction, specifically who are on Coumadin. I'll also make mention intra-procedural for this kind of common techniques that we always use. There might be some increasing challenges with hemostasis, both intra-procedure and post-procedure, just given the nature of some of the LVAD pumps. And so routine pressure dressings, significant time spent towards achieving hemostasis are important. I would also say that while probably ultrasound-guided vascular access is common, the fact that many of these patients do not have pulsed arterial waveforms might make it more required than even in the normal case. So going back to our case of our 65-year-old gentleman with E. fecalis bacteremia, we proceeded with lead extraction, which was uncomplicated. He had an uninterrupted Coumadin, and so we did it with therapeutic INR. And he remains on long-term antibiotics to suppress the E. fecalis bacteremia, and so far has done well. Thank you very much.
Good afternoon. This is Dr. Robert Schaller from the University of Pennsylvania. I'd like to review our experience with percutaneous balloon venoplasty for symptomatic lead-related venous stenosis. Venous stenosis is very common after implantation of CIEDs, and patients who have greater than 50% narrowing or stenosis in their veins make up a large percentage of patients with transvenous devices, but it's really only relevant when we're trying to upgrade or revise these systems, because most patients are not symptomatic, but when they are symptomatic, it can be quite bothersome in up to 5% of patients, and it can lead to swelling. Now, venous thrombosis is pretty common after implantation of devices, especially de novo devices, and it's due to insufficient blood flow due to an acute thrombus because of the lead that's now in the vein. This occurs days to weeks, sometimes a little bit longer after implant, and these patients typically don't have collateral circulation formed yet, and they can present with pretty dramatic swollen arms or necks. And the treatment for this is anticoagulation. They usually respond very nicely within 30 days, and it usually isn't a problem thereafter. Venous stenosis, on the other hand, is a different animal altogether and has a different mechanism. It tends to be more of an indolent type of presentation and is due to an inflammatory reaction in the vein due to the leads being present. And this can occur from months to years after implant. The problem is that sometimes they don't respond to anticoagulation. In fact, they frequently do not, unless there's thrombus on top of stenosis going on. And the long-term issue is that this chronic edema can lead to a irreversible secondary lymphedema because of the increased pressures in the tissues. And this lymphedema can be irreversible and quite problematic if left untreated. And this can occur in the arm or the neck or the face, but it can present itself in multiple different locations, even in the same patient. And in UPenn, our strategy of dealing with this issue is to start oral anticoagulation immediately upon the diagnosis, and then to acquire a non-invasive imaging, either ultrasound or CAT scan, to see if we could localize where the lesion is and get a diagnosis. But importantly, if there's no improvement at 30 days, then we bring them in for an invasive venogram with the possibility and likelihood of doing venoplasty during the same time. In the interim, we reassess their need for a device in general, because we know that if the device and specifically the leads are causing this issue. So if we could remove that and use a different solution, then of course you can, but you can't do that with every patient. If a patient does have lymphedema, which presents differently, it's more of a non-pitting, puffy type of edema, then we will send them to a lymphedema clinic. The two types of balloons that we use at our hospital are just a regular non-compliant balloon that you could inflate up to about 10 or 12 atmospheres. And it's pretty good at opening these lesions. But sometimes there's a napkin ring type of lesion, or really, really calcific or fibrotic part of the lesion that you just can't open. And we use an ultra non-compliant balloon. This one, it's called a conquest balloon, and it can make a real difference. Sometimes you just can't open these with a regular balloon. So we use this if the regular balloon will not open the lesion fully. And what we try to do is identify the lesion with a peripheral venogram and then cross it with wires if you can. That way you don't have to remove anything. So we use a hydrophilic wire and a hydrophilic catheter. And in some patients, about 50% of patients, you can cross these lesions. And then I like to do a local venogram just to get a better lay of the land, see exactly what the collateral circulation is and see if there's one or multiple lesions in this vein. We'll proceed to venoplasty, and usually it's pretty satisfying to see this focal region of the vein open. And a common question is, how big of a balloon do you use? Well, we typically try to size a balloon based on how big the adjacent vein is, and sometimes you could just estimate it. And sometimes you go a little bit bigger even after the first insufflation of the balloon if you think you can, but we try to limit it to right around the size of the adjacent vein. Here we used a slightly bigger one. We thought we can get away with it. It's a very safe procedure. And then a repeat local venogram will show that flow is restored. In this patient with facial symptoms, it wasn't a surprise to see that the innominate system is actually open, but there is a stenotic segment of the SVC. So once we see what we're dealing with, we try to approach that from a better angle, which in this case would be the right internal jugular vein, where you can see the local venography shows some narrowing of the SVC. We'll perform venoplasty with really as large of a balloon as we can find, because it's rare to find a balloon more than 14 millimeters. And that tends to be what you need to open up the SVC. And of course, flow is now restored in the SVC. Sometimes it's hard to see how much the flow has increased, especially when there's competing circulation here with the azygos. Probably a little bit of flow is going through the azygos, but you can usually see that it's much more open than it was before. If the lesion is very complex and long, it would be unusual or challenging to cross that with a wire, and sometimes you'll have to remove a lead in order to get into the same lumen, so that venoplasty is most effective. And one really nice way to do this is to remove a lead from below. Typically, these leads haven't been in for decades because they usually present a little bit earlier. So you can usually just pull one off of the wall, and if you could snare it with a wire in the lumen of the lead, you could then pull the lead through the groin, and then you're left with this wire traversing the vein within the natural lumen, which is quite convenient. You could perform venoplasty. It doesn't really matter how long the balloon is. Usually we'll use a shorter one, but you can see that there was a nice lesion right here. And it's very important to make sure that there aren't multiple lesions. And here you can see that there was a really tight stenosis within the subclavian vein up here between the vein and the rib, which required an ultra non-compliant balloon to open it. And once both of those lesions were open, then flow was restored. Here's a patient with chronic edema. This is actually chronic lymphedema. It's puffy edema that tends to have a bluish or speckled, sometimes reddish, bluish speckled appearance. And this patient presented very late, years after the arm started to swell. And you can see that he's completely occluded right here with collateral circulation. This patient actually had a lymphogram, and you can see the lymph moving here apparently very slowly. I'd never seen a lymphogram before, but this is highly suspicious for secondary lymphedema. So this patient had a poor prognosis in regard to the arm. But we tried. In this case, we used a laser sheath to get across the venous occlusion, kept the lead in place with a snare from below, crossed with the laser sheath, dropped a wire right here, and then removed that lead. And then we went to work on the vein. It's more open now because a laser sheath has progressed, but we still needed to perform venoplasty, which we did here. And then we used a bigger balloon and placed a stent. You can see the stent starts here and comes all the way down through here. We don't typically use a stent, but in this case we did and had a nice result. You can see that there's nice flow through the stent. This patient needed his device, so we reinserted all of the leads except for his epicardial lead through the stent, and he had a very nice result. But unfortunately, his symptoms never improved, and a couple of months later, we evaluated the stent, which was once again completely blocked. So this was a learning opportunity here, and a lesson learned, which is that stents and veins really don't go terribly well together, and you should probably avoid using them if you can. Eventually, this patient just received a completely surgical BIV ICD after everything had to be removed due to bacteremia. Now, in some patients, you can't use contrast because, like in this patient who had a swollen left arm about a year after implantation of her system, and there was pitting edema, so we thought that we had a good chance of making this better. But she was just on the cusp of needing hemodialysis. So we used what we call balloon mapping here, meaning no contrast, and we just kept blowing up the balloon more and more proximally until we found the waist. And that was the lesion that we identified there. And then you can continue to move the balloon back and forth and more proximal until it was completely open. And we never got a sense of the flow here, but we know that the vein was open. And then we removed everything and implanted a leadless atrial pacemaker. Now, some patients are going to recur, of course, especially if they have leads that remain across the stenotic region. Here's a patient who had a swollen neck, and she had an occluded proximal segment right here. We performed venoplasty with an excellent result, but she still came back with a recurrence. You could see the stub right here. And we actually removed everything, performed venoplasty, and moved the system to the other side, but she still recurred, which is pretty rare, without leads on that side. And you can see here that not only is the flow stopped right here at the yellow arrow, but she also has this collateral circulation that includes this venous webbing in her neck. And this was what was causing all of her symptoms. So some patients just get unlucky where their collaterals form. And she actually required a venous reconstruction and resection of the first rib for complete recovery because we just couldn't cross this section anymore without leads. And she had three percutaneous procedures and just kept recurring. So in our study, we looked at 18 patients who had refractory swelling. Some of them were just in the arm, and the other 8 were arm and facial swelling, and one patient with only facial swelling. Many of them had non-invasive imaging before the procedure, but you can see that ultrasound failed in 44% of the cases to identify where the lesion was, and that's just because it's too medial, too central for an ultrasound to see it. CT performed a little bit better with 11% with a misdiagnosis. There was a smattering of different types of devices. It really doesn't matter what leads there are in the veins, and the lead dwell time was a mean of 3.1 years. So the 18 patients had 28 procedures performed, 27 venoplasties performed, including the one surgery that patient had, with a mean of 2.1 balloons used per case. And you can see that they had very nice responses as long as there wasn't lymphedema present. But 5 patients required more than one procedure, some of them requiring up to 4 procedures, and many of them having a lead extraction procedure during the initial venoplasty procedure. The vast majority of patients improved, but some patients were left with a partial improvement, meaning that the edema was significantly decreased or completely gone. But if they had developed some lymphedema, that lymphedema was still present. That's what we call a partial improvement. Some patients, the one patient I showed you had only lymphedema, and he had no improvement whatsoever. But you can see that most of the patients no longer had leads that crossed the stenotic segment, at least after their final venoplasty procedure. So I'll show you the results here. So the major results of this study was that non-invasive imaging is modestly effective, but CT outperformed ultrasound. Balloon venoplasty is very safe and effective to decrease or really cure edema in patients who have not yet developed lymphedema. Unfortunately, if leads still span that stenotic region, they are at risk for recurrence. Now, the long-term success of a single venoplasty procedure with leads spanning the stenotic region is only 33%. So 1/3 of patients will have long-term success if you leave the leads in place. On the other hand, if there's no leads spanning the stenotic region, so you perform the venoplasty and remove the leads, it is very rare to have recurrence. So you have to take that on a case-by-case basis. In terms of symptom onset, if you had complete recovery versus if you were left with some degree of lymphedema, there was a significant difference in terms of length of time that the leads were in place. So you want to address this early to decrease the chances of developing a lymphedema, because venoplasty is significantly less effective for secondary lymphedema, even if you're able to decrease the edema by treating the vein. So you really want to nip this in the bud before lymphedema occurs. Now, all hope is not lost because we performed a similar type of analysis in patients where we started to use the Medtronic drug-eluting balloon catheter, and this elutes paclitaxel. And we performed this in 14 patients who had very similar types of presentations of swelling in their neck and arms. And the way that you do this is similar. You identify the occlusion, you try to cross it if you can without removing a lead, and then use the same type of balloon in order to open it up. The difference is that after the vein is completely open, you could then use the drug-eluting balloon as a chef's kiss, if you will, to try to deliver the drug right at the end of the procedure. You keep the balloon inflated for 3 minutes, let the drug seep off into the vein, and then, of course, flow is restored, and then you hope that in the future they won't recur. And the results are different when you use a drug-eluting balloon. You can see that most patients did not require lead extraction here, and most patients only required one procedure, with the vast majority of them having symptom improvement. So there was durable relief in over 70% of the patients after a single procedure, despite the vast majority of them maintaining leads across the stenotic region. So there seems to be added benefit to utilizing a drug-eluting balloon at the end of the procedure. So our recommendations are, if you have peripheral swelling in a CIED patient, then you should initiate anticoagulation and consider doing non-invasive imaging. But if you do, probably better to order a CAT scan rather than an ultrasound. If there's resolution, that's great. Continue the oral anticoagulation for 3 months. If there's no improvement after 30 days, prompt venography and venoplasty. Do not let this wait. And if you're going to perform venoplasty, try to utilize a drug-eluting balloon if you can, and avoid stents if you can. At the same time, consider removing everything and using a non-transvenous CIED, either no system, a leadless one, a non-transvenous ICD, or a epicardial system at that time, because the results will be better. If you can remove all of the components that are going to traverse that region, so you've transitioned to something leadless and there's resolution, that patient should do very nicely, and you could continue anticoagulation for 3 months. If there's no recurrence, if there's no resolution, there's recurrence. So you can either repeat the procedure, you can consider surgery, and that also means that there's probably a high degree or high likelihood that that patient also has some degree of lymphedema, and you should refer them to a lymphedema clinic. If you do not remove the transvenous leads in this patient, then you probably should anticipate a repeat procedure, because upwards of 30% of patients will require a repeat procedure, even if you use a drug-eluting balloon. So it's important to set expectations appropriately. And we don't know how long you should utilize anticoagulation in that patient, probably longer, though, than 3 months. So I'd like to finish with one nice case that we did a couple of years ago at a sister hospital of a patient with a very low BMI. Here is a lesion in the SVC in a patient who is quite symptomatic. We were able to cross this with a wire and utilize a very large balloon to open it up. Flow here has been restored, and we had a very happy patient indeed. Thank you very much.
And now we are going to have a great discussion. So first of all, we are going to begin with Dr. Saleh. There is some more technical question for you. So how do you perform your closure of the femoral approach once you're done with the extraction?
So that's most of the time, if it's not anticipated that you're going to go ahead and go from the femoral approach, and you end up using a 27 French sheath, or even if you're using a 16 or an 18 French sheath, I end up just putting a figure-8 suture down. Either you tie it down, or you can use a 3-way stopcock to hold that suture together. If you're anticipating ahead of time that potentially, listen, I think I'm going to end up using the femoral approach, then maybe when you get your access up front, what you could do is you could always put two pre-close, put a per close down, two down. You always upgrade to your big sheath, you do your extraction, and then you can just finish your per close at the end. But that does require some anticipation ahead of time. It does add cost to the procedure. The 3-way stopcock, the figure-8 suture and 3-way stopcock's what I usually prefer to do. It's just convenient and it works. But that usually is an approach.
Okay, thank you. And can you explain us your workflow when you decide to go by femoral approach? When are you deciding to use the catheter ablation? What kind of catheter ablation? The bioptom or the lasso or the needle ice? Do you have every tools for every situation? So how do you prep your extraction?
So every tool that I showed on that list, we actually have a cart in the OR that's an extraction cart, and we have all the tools present. So the reality is when you decide that you want to use one of the tool's right available for you. No one's running around and trying to find it. Using what specific tool really comes down to what you're trying to get. So if the lead is still intact, the body of the lead's intact, and you have good enough of the lead to grab onto, using an ablation catheter or a needle eye snare, or just being able to get a gooseneck snare around the lead is feasible. And really, when it comes to ablation catheter, my preference has always been to use a blazer, because it's one of the few catheters where you can get this very, very tight turn around the catheter, kind of turn on itself, and it gives you, good security. A lot of places don't have blazers, but we happen to carry them just for extractions. But if you have a small thread, like with the case where I showed, where it's you have that small thread of the lead, and it's going to be very difficult for you to be able to tell, well, did I get a gooseneck around it? Am I going to be able to get a gooseneck around it? The bioptome may be easier to get a hold of that end and then pass the gooseneck over that. My go-to most of the time is if the lead is still attached to the heart and there's a substantial amount of the lead still going up into the SVC. I take a needle eye, I go up, I just wind the whole thing together to create a good grab onto the lead, and I pull the whole system down while putting counter traction with a micro sheath, and that usually takes care of it.
Perfect. I have just a very technical question for you. One of my nightmare with the microsheet is the leaking of the valve. So how you deal with that? Have you tried the Avir sheet with the strongest valve that we can see on the market?
So I have not used the Avere sheath for this, which you can. I've only used the Avere sheath with the Avere extraction system. What I end up doing a lot of times is I just backstop it with an 18 French Cook sheath to prevent some of that back leaking. Part of the reason why a lot of times, historically, why we went straight to the micro up front is a lot of times we used to just have the micro sheath in because we would implant a micro up front before the extraction, someone who needed an extraction. And I do find it, kind of simple to go there. The other thing is that if I end up having to add more things in, I can always take that 18 French sheath out. But usually the 18 French Cook sheath inserted in there allows you to stop that back bleeding.
And last question for you. Do you have any situation that make you less enthusiastic about the primary femoral approach, like the dual coil ICD lead and the venogram, the upper extremity venogram? Does it help you to decide if you are going from the below or for the upper approach?
So it all comes down to what the intention at the end is, whether you're planning to reimplant or not to reimplant. And I think if there's an intention to implant a transvenous system from up top, it behooves you to always to try to approach from up top first, especially when you have an occlusion to maintain access. When it comes down to, do I ever go straight to from below, especially if I have a dual coil system or something like that? But I personally always try to extract from up top if possible. If the lead broke, like that one lead that I showed where, it broke the dual coil, most of the time what happens is the area where you break up top is usually where the lead's bound to the vein. And so you tend to almost 90% of the time able to pull the rest of the coil safely without a lot of resistance from below. Sometimes you're unable to do that, right? And the coil continues to be attached to either the vasculature or the other lead or what have you. And people worry, well, are you going to be able to safely pull that from below? What tends to happen in those cases is that actually the coil just starts to unwind as you pull on it. So even though it's attached, you're not putting a lot of stress on the vein itself. The lead unwinds. And so as you just carefully do that, you're able to unwind the entire coil and pull the whole lead out without causing significant damage to the vasculature or causing a perforation up top.
So thank you so much. Now there's some question for Dr. Kapoor. Actually, there is a lot of question about the management of ICD in LVAD patient. And do we need to change the battery at the replacement? Do we need to extract the device alone and let the leads in place, or do we let everything in place? So there's a lot of question about that.
Yeah, it's a great question, and obviously it's a challenging situation. This is kind of the cliched multidisciplinary or team approach where we're obviously working very carefully with the LVAD team, the heart transplant team, and sometimes it makes a big distinction of whether or not they're a destination or whether or not they're a bridge to transplant type LVAD. I think we historically have a strong degree of importance for what an ICD does for our patients with cardiomyopathies. But I think we sometimes forget that the ICD in the LVAD patient is a very, very different situation. And the things that we would normally think as being not acceptable, turning off leads, abandoning leads, letting patients hit ERI and not changing it, is maybe a little bit different in the LVAD population. So I think certainly there's a lot of role for extraction, lead revisions, generator changes, but it's kind of on a case-by-case basis. The complications in LVAD patients, I think we've all appreciated, can be a little bit more severe and a little bit more challenging. They're bleeding diatheses from the LVAD, depending on the type of pump. Even a simple generator change can be a long procedure. So I think it's very much on a case-by-case basis.
And what do you think about the LV lead in LVAD patient? Should we turn off the CRT or should we let the CRT on?
Yeah, I think that for the vast majority of patients, and again, I'm sure everyone could pull up an exception to every rule, but turning off the LV lead is a very reasonable approach. That resynchronization is probably less helpful. And I think whatever we can do to preserve the battery, turning off the LV lead, turning off, non-essential diagnostics, and kicking any possible generator change down the road is a really valuable thing. So I would say routinely, unless there's a unique situation, we'll turn off a lot of the LV leads, we'll turn off unessential diagnostics and pacing, as well as make some changes to programming. I think a lot of LVAD patients, I'm sure a lot of us have seen, will come in, walk into the hospital in VF. And it's probably better to have them walk into the hospital and get electively defibrillated with anesthesia as opposed to getting shocks at home. So changing even the tachytherapy programming can be an important portion after they get their LVAD.
And a last question about how do you manage anticoagulation procedural for the extraction in LVAD patient, given the platelet dysfunction and the anticoagulation you have to stay on in LVAD patient?
Yeah, it's a really, really important point because again, these patients are prone to bleeding, and specifically when we're doing more extensive debridement up in the shoulder or pocket revisions. I think we try our best to manage them, but I would say my general approach is to defer to the LVAD team, meaning that a lot of them will not want them to come off their Coumadin or come off a therapeutic INR. And I think, in much of the extraction literature, we found that to be relatively safe. Maybe it becomes a little bit of a longer procedure, maybe a couple extra techniques needed to manage pocket bleeding, but I haven't routinely been going through reversing people unless there's kind of intra-procedural complications.
Thank you. And now we're moving to Dr. Scheller. How important is to document the loss of collaterals after venoplasty? Do you think outcomes could change, like reocclusion or symptoms, if we don't decompress the collaterals?
Yeah, collaterals. It's satisfying to see the collaterals go away. I think it's a surrogate for increased flow in the main vessel, but I don't know if it's important to make them go away. It certainly is when you think the collaterals are causing the problem, like with the venous webbing in the neck. Their symptoms go right away when the collaterals go away and the flow is restored. But maybe it's better to have a little bit of collateral circulation competing with the regular flow to mitigate any symptoms in the arm. We just don't know.
And do you have any comparative data comparing stents and balloon alone in the venous stenosis or thrombosis management?
Yeah, stents are interesting. They bridge many different disciplines because there probably aren't too many EPs putting stents into veins. And but I also think that the EPs have a better sense of how leads and veins get along. So I think sometimes we get ahead of ourselves. Stents seem to work pretty well in short segment occlusions of the SVC, especially when no more leads go down. But even when leads are placed through the stent, I think they generally are okay. They're short and they're very big. And there are some data that patients do well, but the question is, do they need them? If you could just remove the leads, patients do fine with venoplasty. So if you must put a lead back in the heart and the lesion is in the SVC, I would consider using a stent if primary balloon venoplasty with a drug-eluting balloon fails. Stents in the subclavian and the innominate probably should be avoided. They're usually longer. They're not as big. We have seen a few patients where the stents have occluded, and you could imagine that can cause a real problem thereafter. The one non-controversial opinion, I think, amongst lead extractors with stents is that you really shouldn't jail any leads against the wall of the SVC or the innominate with a stent. You really should remove everything first if you really want to put a stent in.
Do you have an inferior limit of the size of the veins that you're going to put a stent in?
No, I think that if you, again, I think you can, venoplasty is so safe and you can go so big and you can use these drug-eluting balloons and you lose nothing by doing it because you frequently don't even have to open the pocket. So I think you should really exhaust all options and be very aggressive with balloons, as particularly these drug-eluting balloons, before you consider a stent. And then after that, you're going to have to consult your friendly interventional cardiologist or radiologist to see what's available, what are the best types of stents there are, and what is your plan for the device thereafter.
And finally, do you have any tips and tricks for to try to avoid the lymphedema, like external compression or something like that?
No, lymphedema is a real problem, and you're going to hear more about lymphedema in the case during the working lunch. The only thing that we know is that some patients are very unlucky and they get edema, and then some of them progress to lymphedema. And time is not your friend. You have to get those patients in earlier. We have seen irreversible lymphedema in a matter of months. So address it within 30 days of diagnosis. Make sure you get them to a lymphedema clinic where they're going to use those types of compression tools, but they're not terribly successful. And get things out as fast as you can, or else it's going to be years of dealing with this puffy edema.
So thank you all of you for this very great presentation.